Hi, everyone. We're just going to give it 1 or 2 more minutes for people to join, and then we'll go ahead and get started. Thank you for joining today. I'll just get started on just the intro slides, and hopefully we'll have a few more people joining us as we move along. So thanks for joining the first session in our age-friendly geriatrics tele-echo series for the primary care network at UC Davis. This series has been organized for you by UC Irvine's Division of Geriatric Medicine and Gerontology and our Geriatric Workforce Enhancement Program, as well as with our partners at UC Davis. We want to thank Dr. Terry Harvath and Kate Lorenzen for helping organize some of the moving parts. And thank you all so much for taking time out of your day to join us. So this is the structure of all of our ECHO sessions, starting with announcements and introductions, followed by a 30-minute didactic. And today's topic is going to be focusing on the annual wellness visit, best practices. And then we'll move on into our closing and reminders. After the didactic, we'll have a discussion on the annual wellness visit. So just to make sure everything's running smoothly, please remember to mute yourself. You should already be placed on mute. So if you do want to speak up, feel free to unmute yourself at any time. Confidentiality anytime. Always maintain confidentiality when speaking about your patients and refrain from including any identifying information. We are CME accredited, and our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. And today's session is accredited for 1 CME credit. So if you do attend all of our sessions, you'll receive 4 CME credits, and certificates will be sent to you via our CME office to the email address that you registered with. So just a quick grant disclosure, our series is a part of the HRSA Geriatric Workforce Enhancement Grant, and we truly thank you for everything that you do in helping older adults, especially through this trying time. So we're going to go ahead and move on into introductions. And we'll have our hub team go ahead and introduce themselves first with their name, role, site, and location. And if you are not a hub team member, please go ahead and put that information in the chat. We'd love to see where you're joining us from with your name, again, name, role, site, and location. And then we'll go ahead and have our hub team introduce themselves. I'll get started. And my name is Nika Seville. I am the web project manager, and I'm located at UC Irvine Health in Orange County, California. Dr. Gibbs?
Yes, hi, Lisa Gibbs. I'm a geriatrician. I'm the chief of geriatrics at UC Irvine, as well as the PI on this grant, the grant that's responsible for developing the ECHO program. And I'm pleased to meet all of you. Thank you.
Thank you. Dr. Sakel.
Hi, everybody. I'm Sonia Sagal. I'm a clinical professor in the Department of Internal Medicine and Division of Geriatrics and Gerontology here at UC Irvine, and I direct the fellowship in geriatrics here, and my practice site is in Orange, California at the UCI Senior Health Center. Welcome.
Thank you. And this is our main hub team. Dr. Gerbich and Dr. Campbell couldn't be here today, but they will be at our future sessions. And then I know Carlos, one of our hub team members, is here. Carlos?
He may have dropped off. I don't see him.
Okay.
The other hub team members, Dr. Gerbich is a pharmacist who specializes in geriatric care, and she has just a wealth of knowledge regarding anything related to medications. So she'll be in the next few. She had a family emergency today, and Sarah Campbell as well has extensive clinical experience as a DNP. And also a wealth of information, and she herself is ill today. So they are not here today, but they will be here going forward. So we have a well-rounded team for you for this ECHO series.
Thank you. And anyone else on the line want to introduce themselves? Any of our registrants? Okay, well, we'll go ahead and move on into our didactic presentation, which is going to be led by Dr. Gibbs, who's the medical director of the Senior Health Center here at UC Irvine and chief of the Division of Geriatric Medicine and Gerontology at UCI Health.
All right, thank you.
Oops.
Yes, so we wanted to start off with a couple of polling questions. Nika, can you lead us through these, please?
Sure. Carlos, you want to launch that?
Yes, give me 1 second. I had a little bit of a technical difficulty.
Oh, I can do it. I can do it. Here we go.
Okay, thank you.
Okay, so how important do you believe the annual wellness visits are for the care of your continuity patients? If you can click what you think is the answer, not at all important, slightly important, important, fairly important, or very important. And you can make sure if you want that your answers will be anonymous. So. Okay. Okay, let's share those results. Can you see that?
Yes, so 40% important, 40% fairly important, and 20% very important. Okay, that sounds great. And we can hopefully have some more discourse along the way to understand why people feel like it is important.
Okay. Okay, next poll question. There we go. How many annual wellness visits do you guys conduct per year on estimate?
Nika,
Rapid-
Michelle Dossett says she's not getting the option to do the poll.
Oh,
I'm not either. It's actually just showing me the results.
I'm not even seeing the results or the option either. I was gonna.
Like I have the
Oh,
option
I'm
to end
sorry.
poll.
oh, I don't know why. If you can't see the poll, I know like half of them are submitting it. So if you don't see it, go ahead and put your answer in the chat if you can. Sorry about that. I know if you don't have the updated version of Zoom, you might not see it.
That might be the issue. Yeah.
Okay, looks like we have about 5 people and we have some answers coming in through the chat. So less than 5, more than 30, about 5, and then we have 2 out of 5 saying 20 to 30 and 3 out of 5 saying over 30. So
Wow. Okay, so people are doing them, and some people are doing a little bit less. 5. Oh, over 30. Oh, okay.
oh, sorry. Oh, that's
All
good.
right.
Great.
Okay, so it's great to know that people are familiar with them and doing them. Okay, thanks, Nika. So today I'd like to review the annual wellness visit. I'd love to hear your thoughts. I don't mind being interrupted during a presentation at all. I have to admit, a few years ago, I was not very enthused about the annual wellness visit. But yes, Dr. Sagel, you are smiling. I can see that. But as I've worked with it, and actually, I direct the ACO here, and we decided that we would focus on this as a way to improve our quality measures. So I've been working extensively with the annual wellness visit now for a couple of years, as well as with our IT team, to integrate it in a new way into Epic. So, the point is, I guess I've developed an appreciation for it that I really didn't have in the beginning. So this is where I'm coming from. And hopefully, a lot of you are doing these already, but I hope to at least present some new information, maybe some information from a new perspective, so that we can learn to appreciate this a little bit more. So basically, I'll be covering, as you can see, the what, why, how, who, when, and where of the annual wellness visit. Next slide, please. Okay, so the what. So as a geriatrician, and by the way, are there any other geriatricians in the audience today? Just throw it in the chat or speak up if you'd like. Oh, okay, great. Alia Tugan, thank you. Dr. Tugon, nice to meet you. So, and you'll know, as you look at the annual wellness visit, that the geriatric assessment is really incorporated into the annual wellness visit, meaning that it covers a review of medical conditions and syndromes. We look at medications, we look at function, which is a geriatric like hobby. We look at social determinants of health, and we also cover prevention, screening, and ACP, so advanced care planning. So I tend to see the annual wellness visit as a microcosm of the geriatric approach to patients, and it's a very person-centered, holistic approach. Okay. So let's move on to why. I've learned to appreciate that, number one, it disrupts the cycle of treating disease. Meaning that, when we have a person coming in for the annual wellness visit, we are all of a sudden just focusing on the other parts of their lives, and we're focusing on how to maintain their health, and we're focusing on what really matters to them, instead of, coming in to follow up on the diabetes every 3 months or the dementia every 3 months, et cetera, et cetera. This is an opportunity to talk about different things. And so I've learned to appreciate that. Number two, it provides an updated, comprehensive view of our patients. It does allow us to find new diagnoses, and I'll talk about that in a minute. But I also learned cool things about my patients that I've never learned before, and some uncool things about my patients, which we'll talk about. But it does provide just a different viewpoint and more of a comprehensive view. Number three, quality of care. So it's really can be a one-stop shop ordering for prevention and screening tests. And again, I don't know about all of you, but before I really started doing a lot of these, I would finish my visit with my patient, and then I would instinctively or reflexively go to the healthcare maintenance list saying, okay, what have I missed? What do they do for? And so it just kind of was an add-on to every single visit. Now I know that when I do the annual wellness visit, I can just do it at one time. And I don't have to just remember to do that with every single visit they're on. Number four, there is a real business case for the annual wellness visit. There is a return on investment. Number one, when we review the medical conditions, it's really a perfect time to make sure that that list is accurate, because there may be diagnoses that aren't on it that may improve our HCC coding. And we might find that a lot of the codes, HCC codes, haven't been coded that year. And in that case, sometimes we're bringing patients back to make sure that we can do that before the end of the year. And of course, whether you're familiar with HCC coding or not, when you can code more of the hierarchical codes for CMS, it increases your RAF, which tells, basically Medicare how complex your patients are. So it's really important when you're dealing with negotiating contracts and Medicare rates and so forth. Next, RVUs. I'm going to talk a little bit about the numbers of RVUs. But if you do this in a very prescriptive way, the RVUs are well worth your time. And thirdly, it benefits quality programs. So all of you know, I'm here, UCI is completely focused on improving our quality programs because we have a number of them we have to satisfy in order to have a return, like PRIME or QIP. And some of you may not, those may not be familiar terms. But certainly everybody knows that UC Davis also has to satisfy certain quality measure thresholds in order to reap the rewards or pay the cost. So lots of whys. Let's move forward, Nika. I like to highlight the RVU argument. This I searched the internet and came up with these tables. If you compare, let's just go to the top table. If you go to a 99214, for instance, the calendar year 21 work RVU for that is 1.92, significantly increased from 2020 because they overhauled not only the documentation, but the RVUs. So you can have a 1.92 RVU for 99214. If we go down to the second table and we look at the initial annual wellness visit, the G0402, you can see that proposed 2021 RVUs is 2.6, very significantly higher than the 1.92. And if you're bringing a patient back for a subsequent annual wellness visit, you still have the 1.92, which makes it very equivalent to a 99214 when it comes to RVUs. So it's well worth your time to do these. And I think, you know, Medicare has done this for a reason. Okay, any questions about that? Okay, so when should we do this? Well, I just want to make the distinction between the Welcome to Medicare visit, which happens when a person is eligible, their first year of eligibility for Medicare, the initial AWV. And so this is an option for beneficiaries who've already been in Medicare for a year. So what Medicare would like us to do is do the Welcome to Medicare visit in the first year. And then after 12 months, we can do an initial annual wellness visit. And then 12 months later, we can do the subsequent annual wellness visit. And so that's a timeline. Of course, now since, you know, the uptake for annual wellness visits has been sporadic with different health systems and different providers, you know, we may find someone who's been into Medicare and age 75 for 10 years who's never had an annual wellness visit. And in that case, you could bill an initial annual wellness visit at age 75. But we do need to wait 1 year between each of these. Okay, Nika. Okay, who may perform? And this, I think, is really one of the benefits of annual wellness visit. Of course, we can have a physician perform it, but we can also have a qualified non-physician, physician assistant, nurse practitioner, pharmacist, nurse, you know, so all of our allied professions can perform this as well and bill for it. And also they said, yeah, and you can have a health educator, you can have a registered dietitian, or any other licensed practitioner, or a team of medical professionals working under the direct supervision. And I have a question here in the chat. Yes, what about patients? Yes, my understanding is yes, for dependent adults who are less than 65 who have Medicare, it's a Medicare beneficiary right. Okay, thank you for that. So what this shows us is, you know, Medicare is allowing a lot of different professionals to perform these, which gives us a lot of flexibility in how we want to structure this in our practices. Okay, next slide, please. And where? So I bring this up because obviously we do it in the clinical setting. Actually, I should have also added home visits, right? But I did add video telehealth because right now we're still in a public health emergency and Medicare is allowing us to do these via video, not by telephone, but by video. One problem with that is we often don't have a blood pressure. And so during a public health emergency, you know, they say you can just state no blood pressure available, or you can ask the patient, even better, to provide a patient reported blood pressure. Okay, so right now, and actually it kind of makes sense to do a video visit, especially if you can get a blood pressure, because there's no physical exam involved in this visit, as you know. Okay, move forward. Thank you. Okay, how? So we're going to talk, most of our time will be spent on the how, because there are many, many ways to structure this. One clinician can do everything themselves. We can have the patient participate by filling out their own healthcare risk assessment, or we can have a team like we do at UCI, and I'll let you know how we do it here, just as one example. But when we do a team-based model, it's nice because we can encourage members to work at the top of their license. You know, the clinician, whether it's a physician or NP or PA, you know, we don't need to particularly ask all the patient questions. I mean, a lot of that can be done prior to the visit, so we can really focus on the things that a clinician needs to do. And if you look at different healthcare systems and the way different clinicians do the annual wellness visit, you'll see a lot of variation. But the only thing I must caution is that we have to include the CMS mandated components. But I've seen other systems include like diabetes foot exam. As we know, there's no physical exam, but some systems say, when you do annual wellness, please include the diabetic foot exam because we as a system want to make sure that gets done. So you can see a lot of variations in terms of what people do, and I'll also be showing you a couple of variations that we've decided to do at UC Irvine. Okay, next slide, please. Okay, I don't want to spend too much time on just the these slides, which are a little dry because they're lists, but I will hit the high points. So first of all, we need to do a health risk assessment with our patients. And this information, the reference for this was noted on the prior slide. It's a CMS site, by the way, so if you wanted to review that, you can easily go to the reference. So we need patient-reported information. Now, they make a point to say you or the patient can update this information before or after, or excuse me, before or during, and it shouldn't take more than 20 minutes. And we're going to talk about time in a little bit, but if you spend 20 minutes, in a 30-minute appointment, or even 20 minutes in a 20-minute appointment, just getting this information, clearly there's not enough time to do everything. But at a minimum, again, I'll hit the high points: psychosocial risks, lifestyle risks, behavioral risks, and specifically the activities of daily living and the instrumental activities of daily living, which is the function. And so all of this in general is really part of patient survey. And again, not something we necessarily need to do during a visit. Okay, next slide, please. Okay, in terms of, other things we can actually solicit from patients themselves, include current patient providers, including DME suppliers, specialists, other allied professionals like physical therapy, psychiatrists, psychologists, and so forth. So we're asking for just a complete list of who's on that patient's care team, because some of these providers may be outside our system, which is important to know about, because oftentimes, of course, treatment decisions may happen, and when we're not aware of it, it can cause conflict. Okay, and may not be safe for our patients. Next slide, please. So during the rooming procedure, they're asking for, routine measurements that are important. And of course, the first one is blood pressure. And they are asking for a weight or a BMI. They're not specifically asking for anything else, but again, deemed appropriate based on the medical and family history. So that's where they leave open to a lot of flexibility. Okay, next slide, please. Okay, now here's where the clinician comes in. This is the areas that I feel that clinicians must and should do. In terms of reviewing the medical history, again, for us, this is a way for us to ensure that the medical list is accurate. And most of the time it's not entirely accurate. So this is one chance per year to go through and clean it up. I often joke with patients that this is the one visit where I can make you healthier, because I am going to delete a lot of medical conditions that either no longer have or never had in the first place. So they're usually pretty happy with that. But my other, reason for doing this is to make sure it's accurate, so that I can make sure I can code the HCC coding either then or at a later date. And so past medical surgical history, recent hospital stays, etc., healthcare utilization, and also reviewing the medication list and making sure that it's accurate is part of this section. Okay, next slide, please. All right, detecting any cognitive impairment that patients may have. This is an interesting topic, actually, because there are some reports in the literature that because we do annual wellness visits, we've picked up more cognitive impairment and more cases of dementia that we hadn't known about before. So people are starting to study this, and you can see this one article from Health Service Research, the effect of direct cognitive assessment in the Medicare annual wellness visit on dementia diagnosis rates. This is an interesting topic too, because if you look at the top, CMS says, assess cognitive function by direct observation, considering information from patient, family, friends, and caregivers. Consider using a brief cognitive test. So it's not actually saying that you have to. It's saying, let's just observe. In your observation, what do you think? Is there a cognitive issue here or not? And is there somebody with the patient that you can ask? So it's a little bit, you know, as geriatricians, we always feel like, you know, we should in most cases do like a mini cog or a other short, brief cognitive screening. But, you know, on the other hand, you know, as you know, aging happens in deciles. So oftentimes we have perfectly healthy 65 to 75-year-olds who are still working. They're still functioning. I mean, there's really no question that they're cognitively doing okay. And I had a patient yesterday who just couldn't wait to get through the risk assessment because, you know, she just really didn't see the need for some of these questions because she was so functional. So does every patient need a cognitive screening test? I would argue no, but you will also find other people that say, yes, you must do this with every patient if you're a geriatrician, or you must do this in a geriatric way. Next slide, please. I'll show you one pathway that the Alzheimer's Association has come up with to kind of bridge these arguments. And what they say briefly in terms of the observation is by observation, are there signs or symptoms present with this patient in front of you? And if you say no, then they ask, is there an informant available to confirm? And if you say no, then they say, well, you can consider then a structured assessment like the mini cog. If the informant agrees, yes, nothing wrong, I don't sense anything wrong with his cognitive abilities for this patient, then you stop there. This is just one, you know, algorithm, and I could show you again what we do at UC Irvine as well. But we're more in line with this algorithm than in line with a purely, you know, a sort of a mandate to always do a cognitive test. But again, different health systems will do this differently. Okay, next slide, please. Okay, in terms of the clinician, now I want to just point out that, you know, at UCI, we include this with every AWV, but CMS actually said in this latest website that I found this week, which was actually updated to 2021, that to provide the advanced care planning at the patient's discretion. Now I will mention that you may want to consider this all the time, just because again, it's an opportunity to sit down and address it. Number two, I don't know how many of you are aware of a new CMS program called Primary Care First, which I know UC Davis will be joining in January of 2022. But there's a new request, CPT2 code for advanced care planning in Primary Care First, which will be a quality measure that everyone involved will be asked to meet, and this would qualify for that. Okay, next slide, please. What I hadn't seen before, and which means now I need to go back to our own Epic system and talk about integrating these, is reviewing the current opioid prescriptions, which we would do, but it says, for a patient with a current opioid prescription, make sure you review the potential opioid use disorder risk factors, evaluate the severity of pain and current treatment plan, provide information on non-opioid treatments, and refer to a specialist if appropriate. And number 11, screen for potential substance use disorders. So this is fairly new addition, which, as I mentioned, we will have to go back and adapt to, but it's good for everyone to know this. Next slide, please. Okay, and then at the conclusion of the AWV, the patient should receive, their own personalized prevention plan, which includes the healthcare maintenance requirements or suggestions that they need to update. Any other screening or referrals that we want to make for mental health purposes or lifestyle purposes, etc. So they come away from this visit with basically a plan, and CMS says a 5-year plan, but they'll come away with a plan for the patient to review and to have so that they can be a partner in their care. Okay, next slide, please. And again, as necessary, I mentioned lifestyle, but they also want to promote referrals into the community. So community-based lifestyle interventions, including fall prevention, nutrition, physical activity, tobacco use cessation, weight loss, and cognition. So now I will get into a little bit about how our system structures AWVs. It's just one way, and I'd love to hear from some of you if UC Davis has done something similar. But, you know, since we've instituted this, and we do have training programs, all of us, you know, we've come across some certain pitfalls, like how long does it really take, right? So in our geriatrics clinic, we have 30 minutes per patient. And I find that that's a pretty reasonable amount of time if somebody has a few complex issues going on. If somebody is, you know, has absolutely no concerns and they're medically very healthy, 30 minutes is too long, you know, and a lot of our primary care physicians have 20 minutes per patient. So that would work out. But on the other hand, there are patients who are very, very complex and vulnerable. And 30 minutes is really pushing a limit for us, or for me in particular. And so I need to make sure that a lot of those survey questions are done beforehand. So one of the pearls is have as much completed before the visit. And the second pearl is don't try to solve anything, right? Just collect the information. Just improve your understanding of this patient and then try to fix it later. And this really is important for our residents because we instituted this in a geriatric clinic in our FQHC, and the residents would find something to you know, a concern, like there's let's say food insecurity, and they would start working on wanting to fix that during the visit. Well, the visit, you know, can go on to at least an hour or more when you do that. So we tell our residents, please don't try to fix anything. Just understand who this person is and what their needs are. And we're going to fix it later, and we're going to provide the appropriate referrals. So there is, you know, there is some strategy in terms of, you know, spending the right amount of time with each patient here. Okay, next slide, please. And again, I just want to see how I'm doing on time. I'll go through these really quickly because we have some questions for you and want to hear from you. But I thought I would just show you some of our new Epic integration at UCI in terms of how we do this. This is an example of an Epic integration. Now, this annual wellness flow sheet starts with everything that the patients can answer themselves. If they are on our MyChart system, they can self-report. They can answer this through MyChart at home, okay? If they are not on MyChart, we have a health coach call them, and the health coach can go through these questions with them, and he or she can fill this out in the clinic. But again, it's prior to the visit. Okay, next slide, please. We'll go fairly quickly through these. And I wanted to point out here that under cognition, you know, as I mentioned, we take the approach where we observe and we decide who may need the cognitive screening test and who really doesn't need it. So if we say, yes, this patient appears to have a memory issue, or we have any type of concerns, and we press yes, then you can see the mini-cog assessment unfold underneath it, and it'll open it up for us. And we chose to do the mini-cog, which is the 3 questions, the 3 memory questions, and asking them to draw a clock. Okay, next slide, please. We also were working on a telehealth program, so we wanted to understand how many of our patients are comfortable with the internet, how many have a cell phone, and how many are comfortable with video conferencing. So we did add that, and that's a variation because, you know, as I mentioned, there are CMS components, and then there are things that you could put into the annual wellness visit because your system decides that that's beneficial. Okay, next slide, please. Safety. Here I wanted to point out that I have a particular interest in expertise in elder abuse. There's no United States Preventative Task Force mandate that we screen for elder abuse with every visit or every year, but I decided, because I could, that I would institute this in our own system. So I added a question that says, has a significant person in your life made you afraid or threatened you, tried to force you to sign papers against your will, or hurt you physically in any way? Now, the science for this hasn't caught up yet, but I will say, on a personal basis, I have thus far found at least 2 patients who are emotionally abused who actually needed a safety plan. So we took a little bit of time to say, okay, so if he, in this particular case, it was and both cases were women, one of whose husband was an alcoholic, and when he drinks, he gets extremely aggressive. So, you know, we basically right then and there took 1 or 2 minutes and said, gosh, you know, what if you need a safety plan? What if he gets physically aggressive? And we talked through how she could leave the house with her daughter safely and where she would go. And so I just point that out because I found this to be really helpful, especially in a world where we know that elder abuse is underreported and underrepresented. Okay, we do ask about firearms. And technically that, again, is a decision that we've made because we've had many patients with dementia who also have firearms in the home, and it's become a real safety issue. We don't ask if people have guns, but we said, if you have access to a firearm, is it in a safe place? So we kind of circumvent that a little bit. Okay, next slide, please. And again, these are additions, as is the advanced care planning, but this is really helpful for us. We just want to know, do you have a healthcare agent? Have you discussed your wishes with the agent? Do you have advanced care directive? And if you do we have it on file? And this really prompts us to be able to request that from our patients in the future. And finally, the healthcare priority is here because we are an age-friendly health system. I know that UC Davis is becoming an age-friendly health system. And so we use the annual wellness visit to satisfy that, age-friendly health system, which, as you know or don't know, is the 4 M's. We have to address mobility, mentation, medications, and what matters most to patients. Ideally at every visit, but most people satisfy this through the annual wellness visit. So we need to add a what matters most to you. So we do that by saying, if we could accomplish or change one thing in your healthcare, what would it be? And this particular patient I saw yesterday said, I want to stay active. Okay. But sometimes people say, well, make me 20 years younger, right? I mean, you get some very interesting answers, which are also makes it fun. But again, this really satisfies for us using this as an age-friendly health system method for IHI designation. Okay, next slide, please. And so at the end of all of this collection of information, we use the phrase ... UCI AWV, and then voila, all this information flows into our progress note. And this is just one sample of how it looks. Okay, next slide, please. Okay, and the other nice thing that we've instituted and built is a order smart set just for the annual wellness visit. It allows us to open up a smart set and bill it, and it allows us to open up any area of concern and just check off the referral that we would like to be made. So if somebody has a fall risk, for instance, we'll just check off referral to UCI physical therapy. Or if we know we want a specific DME piece of equipment, we'll just check off one of those and so forth. So each section has all possible referrals or resources or orders that we'd like to make, depending on what we find. Okay, next slide, please. All right, and here we show that you can just check off your diagnosis, and this will satisfy billing. If you find a memory issue, here we have the option of sending to neuropsychology, consulting with UCI neurology, consulting with geriatrics memory assessment, or referring to a chronic disease health coach, or referring to Alzheimer's OC. So, you could put any number of things appropriate to your own system in something like this. Okay, next slide. All right, so it's just one example of what we've done with it. And, it's one example. I say, if you've seen one annual wellness visit, you've seen one, right? UC Davis might be doing something completely different. But, if we satisfy the CMS mandates for the initial pieces of information, there are multiple ways to use this within a health system to benefit that system. Okay, I think that's it, Nika. I added this slide just because sometimes these questions come up. Is this the same as a beneficiary's yearly physical? The answer is no. And most of you that see Medicare patients know that Medicare does not cover routine physical exams. So this is and again, there's no physical exam portion of this. Are the clinical laboratory tests part of the annual wellness visit? No. You can order tests. Let's say somebody has diabetes and you would like to order an A1C. You can certainly do that, but it's not part of the AWV, and they will be charged for those tests. Whereas with the annual wellness visit, there's absolutely no copay. It's completely free to patients. So if you bring them in for an annual wellness visit and then you decide to do something else, it's great to remember to tell them this part's free, but now when I start, addressing your diabetes or your dementia or whatever it is, this is turning into a more complex visit and you will get a copay for that part of it. So do deductible or coinsurance apply? No, and again, it's free to the patient. So Medicare waives both the coinsurance and the copayment and the Medicare Part B deductible. Can I bill an EKG and annual wellness on the same date? Yes, you can provide other medically necessary services, but again, the coinsurance and the deductible will be applied to the other services. So a lot of times people will do an AWV and then they might address something and want to bill 99213 or 99214. You can do that for sure. But again, the patient just needs to understand that they will then be getting a bill. So that, if they thought they were just coming in for annual wellness visit without any sort of payment, we need to just be clear that they will get a bill after that. We've had some patients call and complain because that was not clear. Okay, next slide, please. So I'm going to stop there. We do have some more polling questions or just questions in general, but I'm just going to stop there first. You see we have